So hello everyone and welcome to our March 2022 Laboratory System Strengthening Community of Practice ECHO session. My name is Francis Ochen from the African Society for Laboratory Medicine. I'm delighted to be your host today. In today's session, we look at generating demand for HIV viral load testing through targeted communication campaigns. And our session will be a 1 hour long session. We'll start with a presentation, actually 4 presentations, 3 from 3 countries and 1 overarching presentation from ITPC. And then we'll have a question and answer session towards the end. As you are aware, we have simultaneous language interpretation. So get to the bottom of your screen and look for the icon of the globe. It's always at the bottom, and choose the channel of your choice. We have French and English channels. Please keep to one of the 2 channels. We also implore you to join the discussions through our chat space. Please ask questions and make comments for the alternative experiences that you may have given this session. As you know, demand creation increases awareness on availability and purpose of service, and also addresses facilitators and barriers of service uptake. And people living with HIV and are on treatment require to take essential monitoring of their treatment response through viral load testing. And WHO recommends that we should have at least 1 test done every year. But we also know that knowledge around the importance of viral load testing as well as test uptake remains low. And so in today's session, building on our previous pilot implementation phase, we have selected country teams that will be sharing with us their experiences on some of the tailored multimedia campaigns that they undertook to raise awareness around routine viral load testing among communities of people living with HIV. And I'm delighted to introduce to you our presenters today. Our first presenter will be Pontsho Pilane, who is the communications consultant with ITPC. She will take the first presentation, and after our presentation, we will have 3 presenters from countries including Tonderai Mwereka from Zimbabwe, Caroline Kasam from Malawi, and Victoria Zindo, who are representative from South Sudan. Allow me now to hand you over to Pontsho to start us off for our session today. Pontsho, over to you. Thank you.
Thank you so much for the introduction. Good afternoon, everyone. I will be sharing my screen just shortly. So as it was introduced, I'll be just giving a brief overview of the country teams and the strategies that were implemented during the hashtag campaign. And this campaign was mainly to improve viral load demand as well as uptake in various communities. And this was the 2nd phase of our implementation. The reason that we were doing this campaign is really to have community-led communications campaigns that look at raising awareness on issues regarding routine viral load testing in 6 countries, mainly being DRC, Kenya, Malawi, Sierra Leone, South Sudan, and Zimbabwe. And you'll be hearing from my colleagues later on who go into an in-depth on those countries, some country teams, and how the 2nd phase implementation happened. We also developed a M&E plan to measure the impact of the campaign to see whether demand creation there was a demand creation, and whether or not there was uptake as a result of that demand creation. And in this phase, this is the 2nd phase of implementation following the 1st phase that took place in October to December of 2020. And this 2nd phase implementation of the campaign took place last year between July and November. The timeline of the ways in which we did the supporting campaign continuation, basically we regathered in about April and May last year to do some more reflection and recap and take some of the key lessons learned in the first implementation phase. And then we developed new messaging and streamlined the various target groups. We also redeveloped our communications plans, depending on which methods worked in the first implementation phase. We changed that according to what the M&E results were, and then we implemented, and then we also developed an M&E plan to measure the impact of the campaign. And as you'll hear later on, we actually implemented a new kind of way of monitoring and evaluating, which is through a post-campaign survey that I'll tell you about. And some of these outputs were a communications plan, as always, indicator tracking sheets to measure the impact, campaign materials that the various country groups were in charge or led in creating, as well as the post-campaign assessments that give us new insights that were very different. And this was the new caveat that we had added as compared to the first implementation. And if we just look at the overview here, these countries, as I said, is DRC, Kenya, Malawi, South Sudan, Sierra Leone, and Zimbabwe. And they had, depending on the country, the needs of the country, and as we remember that these campaigns are led by they're led by community organizations who understand what the needs of their communities are and the country needs. And you see that there are various audiences and various media platforms that were used by these country teams to ensure impact. And for the DRC, we saw that the greatest reach in terms of audience was with the general population of people living with HIV, and through Facebook. They reached most people through Facebook. In Kenya, amongst other target audiences, they also targeted youth, and they were able to reach the most young people through Twitter. In Malawi, the greatest audience, or the audience that was reached the most, were young people as well, and this was done through WhatsApp. South Sudan, it was women who were most reached, and it was also done through WhatsApp. And in Sierra Leone, it was women, and they were reached through the radio. And in Zimbabwe, the most reached audience was men and young people, and they were reached through radio. This is important to think about because each team had about 3 to 4 main target audiences to streamline the campaign, as well as a maximum of 3 media outlets to implement in order to streamline even our monitoring and evaluation at a later stage. I will be now taking you through the DRC's and 2 other countries' outcomes on their campaigns, and my colleagues who are also on the call will then take you through the other countries. In the DRC, our campaign was led by the National Network of People Living with HIV, and their focus audiences were really adult and young people living with HIV, as well as pregnant women. And because it was the DRC, the messaging was in French and Lingala, and the most used platform, or the platforms of choice to use for the campaign, were WhatsApp, Facebook, Twitter, and Instagram. And on the right of your screen, that is one of the campaign materials that was produced. And because again, it is a French country, the hashtag, which is in English is Know My Viral Load, was changed to cater for the audience in the DRC. And a total of 19,100 people were reached through all the platforms. And one of the most impactful messaging there was around undetectable viral load and how it can secure your future, and why it is important to know your viral load. And as we saw in the first implementation phase, we see that demand for viral load testing was generated, but due to the shortages and stockouts of lab reagents in health facilities in DRC, we couldn't, there was kind of the barrier that was more systematic and not around lack of knowledge. And in Kenya, NEPAC and IREP and PYWV led the campaigns in those countries, and they used social media influencers, but they also targeted just general people living with HIV, as well as key population groups. Most of their messages, as you see on the right to the screen, were done through online chats, live, such as Facebook Lives, Twitter chats, as well as Zoom sessions that were held between August and October last year using the hashtag #NoMaViralLoad. And in a way to take beyond just the virtual campaign, the NEPAC community members also took part in protests that were happening in the country due to the lack of reagents again, and demanding that, because when you create demand creation, it's also important that the services are available for the demand creation to be met. And in Kenya, 10,394 people were reached through mostly Facebook, Twitter, as well as the virtual meetings. But as I previously said, Twitter had the highest reach and accounted for about 9,000 of the people reached, which is about 90,000. I mean, 90%, 91% of the overall reach, which goes to show just also where young people are on various networks. And again, they also leveraged a campaign around You Equal You to also spread the message around the importance of viral load. And we can, as we saw in the first implementation phase, because of the very high use of Twitter in Kenya, we saw a lot of hijacking of the hashtag for by non-related parties, and this. So even when we're doing our M&E, it's very important that we sift through that, because the hashtag can be hijacked, and what it does, it then pushes the content from the campaign lower down as other people are using it for their own personal or other reasons except the campaign. In Sierra Leone, natives led the campaign, and we were targeting adults living with HIV, expectant mothers, as well as key population. The country group used WhatsApp. They were in radio, the TV, and radio and in-person engagement in the country, as well as using Twitter and bulk SMSs, but unfortunately those two platforms did not take off as they had hoped or we had intended as well. And there was a combined reach of 16,143 people, and mostly were on radio and WhatsApp. And this again speaks to the various demographic or the various ways in which different demographics in different countries and the digital resources that are available to various countries. So we see in a country like Sierra Leone, radio is a more powerful tool than Twitter. Yet we see in Kenya, Twitter is such a powerful tool. So various countries will have various platforms in which they are able to be successful. And we saw that a challenge that we experienced in Sierra Leone is that key populations, in particular men who have sex with men and people who inject drugs, experience a lot of stigma and discrimination and struggle to disclose their identities, which means that it's sometimes often very hard to reach them in public platforms like radio, and you need a more direct approach and platforms like WhatsApp. And so this is kind of a lesson, not just to Sierra Leone, but as you can see, luckily WhatsApp was also quite heavily used in the country. But to say that with key populations, you often have to use more of what we call closed communication channels due to stigma that exists in society. And as I said, one of the elements that we added in this implementation phase was a post-campaign assessment. And this survey was developed to measure the outcomes of the survey in more detail, of the campaign in more detail. And it targeted the same target audiences as the campaign itself, and the various country teams used the networks in their countries to be able to get results. And it was structured in three ways, in three ways: to assess the knowledge around routine viral load testing, to measure the effectiveness of the campaign to increase awareness about routine viral load testing, and lastly, also to see whether health-seeking behavior as a result, if there was any health-seeking behavior as a result of being exposed to campaign materials. A total of about 188 people were polled in all 6 countries. We did aim for higher, but however, with surveys, it really depends on whether the audience that you're surveying is open to filling it in. And with the exception of 3 people, most people were exposed to the campaign, and the comparisons, they're quite equal. So we were really measuring people post exposure to the campaign. And it also really gave us a lot of insights, which I'll quickly go through as I wrap up. And I think one of the most key assessments that we saw is around the knowledge that people have around routine viral load testing, but also whether or not being exposed to the campaign material led them to tell a friend about viral load testing. And as you can see in the second graph there, it's 83% of people did tell their friends. So what does this tell us? This tells us that when we run campaigns to inform and raise awareness, people are able to really practice health-seeking behaviors, such as at the bottom graph that shows that 76% of people were able to still ask a healthcare worker for their results to be interpreted. And so obviously with this, we need to also work on kind of, it's beyond just the campaign, but working as well on the ground services and whether they're friendly, and particularly if we're thinking about key populations. We also saw that a lot of people showed, in-person meeting. Almost 50% of people said they learned, or their preferred method of learning is through in-person training. And we do know that the pandemic has really changed our ability to do this more. But it was quite interesting to see that, and then to see other platforms like Twitter do quite well, as well as WhatsApp, as I said, and Facebook and other ways that were reached. But we can see that the top 3 methods is in person through support groups, whether it's peer educators, adherence clubs, as well as Twitter through hashtags, and WhatsApp as a more personal, direct way of reaching people. And lastly, if we look at the lessons which I've already shared, is that platforms such as WhatsApp, Facebook, Twitter, and Instagram are useful tools for us to reach audience, particularly in a COVID-19 setting. But we do see that in-person interactions are more preferred and are more impactful. However, we are limited due to the pandemic. And also that that the audience really values dissemination methods that are also quite interactive, where there is a 2-way channel of communication and not just one way. And we saw that when collaboration happens within community organizations, this is strengthened through also the campaign, but also sharing similar messaging. And what that idea, it's a psychological idea of that it's not just a certain community that's thinking about it, and it creates more diversity even in content. But as we see that there are systemic barriers, such as we said, the lab reagent stockouts, as well as other issues around viral load machines breaking down. And therefore, we need to think about perhaps maybe having, including elements of advocacy for these issues to be solved in order to have impactful results. And as we saw with Sierra Leone and Kenya, finally, that key populations do face stigma, and it's important for us to think about more tailored and targeted messagings for their needs, and also to think about platforms that allow for that. So I'll end there, and I do know there will be questions which we can take at the end. Thank you.
Thank you very much also for the very clear presentation. We will now move it to the next presenter. And our next presenter is Tonderai Mwereka from Zimbabwe. Tonderai, over to you.
Thank you very much for that. And thank you everyone for your time and coming here to listen from the communities. Can you confirm that my screen is visible?
Yes, it is. Thank you.
Okay, thank you very much. Okay, so basically, Zimbabwe National Network of People Living with HIV is an advocacy organization that serves the interests of people living with HIV and ensure that their rights are included, especially along the HIV and AIDS cascade. And so routine viral load testing demand creation is one of the key issues that ZNNP Plus work on, and to ensure that there's quality of health among people living with HIV in Zimbabwe. So the campaign was implemented by Zimbabwe National Network of People Living with HIV and the Zimbabwe Young Positives, which is a network of young people living with HIV. And then the campaign materials were developed and deployed targeting the intended groups. And then feedback sessions were conducted to understand the results of the campaign from the recipients of care's perspective in terms of their access to information. So the target groups that we focused on, ZNNP Plus, were young people living with HIV and men living with HIV. So in terms of the platforms that we used peer support, WhatsApp, and radio. And so in terms of peer support, we have peer educators who were trained among men living with HIV and adolescents living with HIV. So for adolescents living with HIV, the peer educators managed to reach out to 600 adolescents living with HIV, and men reaching out to 820 of their peers. And then in terms of WhatsApp, we reached out to 425 via various groups that we have for people living with HIV. And in terms of those, we had 90 men living with HIV and 100 adolescents living with HIV who reacted to the message around viral load testing, and they were mainly acknowledging the message and mainly promising to be proactive on their next clinical visits to the health facility. And then through the radio messaging, this was obtained from the radio station, and they normally use estimates, and they indicated that the message reached in about 15,700 people. But in our interaction with the sector of people living with HIV, about 120 people were reacting to the message that was heard through the radio stations. And their message was mainly also acknowledging that we heard about viral load, that you are encouraging us to seek services around, and that is quite good. We expect to hear more of that, because at times as recipients of care, we might forget certain issues around viral load and miss an opportunity to know about how we are doing in terms of our health. Then in terms of outcomes of the campaign, there was strengthened peer supporting access to routine viral load testing and results understanding. On this one, I might also share with you what we received from the peer educators, especially among adolescent young people living with HIV. So for them, in terms of results, there were some results that were misplaced, that were going to wrong health facilities. But because the peer educators were placed in various health facilities, they were then able to create a network where they then collaborated and inform each other whenever they are to identify the viral load results of a particular health facility in a wrong area, and then they would then demand a criteria for having those results redirected to the correct health facility. What also came through was the issue of, in as much as they were doing demand creation among their peers, what they were also doing was to provide enhanced adherence counseling to some who were having high viral load during their results collection and interpretation. And also, they managed to also engage with their peers and sensitize them on issues to do with potential factors that might affect access to viral load, and encouraging them to be proactive in terms of viral load. And then another outcome was that recipients of care were engaged in the meeting also reported that they were now requesting for more information around viral load and even new information that is coming out, because usually there are some new things that come in terms of viral load, and then the recipients of care were requesting that whenever you come across new information around routine viral load, can you please share with us so that we are able to also understand more issues around routine viral load testing. And then these are some of the personal stories that were collected during the interaction with the recipients of care. There was this young person living with HIV who said there's been a lot of improved access to routine viral load results, especially for those that would have been sent to wrong health facilities. The network of peer educators helped us locating them. Another young person living with HIV said, my peers are now requesting for more information on viral load each time we meet. I'm getting opportunities to share my knowledge with them. We need informational materials. And then this one was a man living with HIV who said, my peers helped me with information on routine viral load, and now I can explain the difference between CD4 count. And so these are some of the personal stories that were collected during interaction with some people who were exposed to the message. And these are some of the campaign materials that we used. These were mainly posters that were placed at health facilities and in some community centers where recipients of care usually congregate and do certain activities. And in relation to these materials, we also use these materials to send them via WhatsApp so that people can share widely. Besides maybe a community center, people can then also, we're also sharing it through the WhatsApp platforms of the various groups that we have. And what is left to say, thank you very much. And this is what we did in Zimbabwe. Thank you.
Thank you very much, Tonderai. Very clear and to the point presentation. I will now turn it over to Caroline. Please, colleagues, keep your comments and questions coming through, and we'll get to them when we get to the Q&A sessions. I will now turn it over to Caroline from Malawi to take us through our presentation. Caroline, over to you.
Hi, everyone. I hope you can hear me. Can you?
Yes, we can.
Am I sharing my screen? Oh, yeah.
Yes.
Okay, so my name is Caroline, and I'll be sharing on behalf of what we did in Malawi. So the hashtag campaign in Malawi was led by Manerela, which is the Malawi network of religious leaders living with or personally affected by HIV and AIDS. We did it in collaboration with COLA, that's the Coalition of Women Living with HIV, and also Y+, which is the National Association of Young People that are living with HIV. So we did this campaign from July to November 2021, and our target audience basically were women living with HIV, young people living with HIV, and religious leaders. And then our main platforms were WhatsApp, peer educators, and Facebook. But however, we had spillover platforms where we would be engaged by various radio stations just to share the campaign. And also we did some posters and flyers, which we shared through support groups and also facilities. And also for those that we couldn't reach through WhatsApp or Facebook, we sent some text messages. So on my right on the presentation, these are some of the key messages that we were sending per target audience. And our main hashtag was be healthy, know your viral load. And here, these are just some of the messages that were being shared. And actually, as people were sharing the messages, we would actually get feedback from the people. So you can see on my left, we posted one of the messages targeting young people, and would get responses like some would want to know more, like where do I get my viral load? And they would even ask more, how do I do this? How often should I do this? So would get a lot of feedback. And on my right, those are also some of the messages that we were sending, and that one was specifically targeting the issue of undetectable and transmission. Undetectable viral load equals and transmission. So those were some of the key messages that we were sending. And in terms of our achievements here in Malawi, basically for us in terms of reach, we actually saw that the campaign helped to reach a lot of people, more especially the recipients of care, through WhatsApp and also Facebook and PLA support. So would send the messages that were specific to them, but at the end of the day, the people that we managed to reach more were the young people that were living with HIV. And through the messaging, we saw that it helped to increase people's understanding and knowledge in terms of issues of routine viral load testing. And it also helped to increase their understanding in terms of the guidelines, like when should they do the viral load, where should they do the viral load, how often, and more especially the interpretation of the results. I think we received a lot of feedback from our target audience that most of the times they get the results, but they were not fully communicated on what that means in terms of the numbers that were recorded in their healthy passports. And at the same time, the campaign basically in our context helped to introduce the concept of U is equal to U to the PLHIV community. And in our context, I think we've had a challenge in terms of going forefront with the U is equal to U campaign. And most of our communities, the PLHIV communities, don't really understand, and they don't have that kind of awareness in terms of U is equal to U until we started the campaign. And through the campaign, we saw that it helped to motivate a lot of our target audience to seek viral load testing and also to demand for their results. The experience prior to the campaign was that more of the recipients of care would go get their samples taken, but would not have or feel empowered to ask for their results. So they would find that time is passing and they don't hear from the healthy care workers just because they were not demanding. And sometimes because the healthy workers are overwhelmed, they wouldn't communicate their results. And at the same time, through the U is equal to U campaign messages that we were passing on to our target audience, it helped them to be motivated to adhere more to their treatment just because they wanted to achieve virus suppression. So we saw that the campaign actually helped in terms of promoting issues of treatment adherence amongst our recipients of care. So this is just more of the messages that were being sent through WhatsApp and also Facebook. And we had some specific materials that were developed. I think on my right, you can see some of the campaign materials that we were also posting online. And then we were also using already existing structures, the WhatsApp groups that we have to pass on the messages. So for like religious leaders, we have already existing WhatsApp groups where I would post the viral load messages, and then the religious leaders were motivated to be change agents so that they were also reaching congregants, more especially those that are living with HIV within their faith communities, also passing on the messages on routine viral load testing. Some of the key lessons learned in Malawi were that once we started the campaign, we noted that within the COVID era, the social media platforms were ideal in raising awareness because of all the limitations and restrictions that we wouldn't meet people in support groups. So the social media platforms actually helped to raise awareness and reach our target audience with the key messages. And it also helped to reach the elite, which most of the times with the interventions that we have, most of the interventions target rural communities. So with the social media campaign, we were also able to reach elite and also both the rural and urban. And in our context, what we also noted was that for young people, Facebook and WhatsApp worked well because when we're using other platforms apart from the social media platforms where you're bringing together maybe young people, it's difficult to mobilize a lot of young people to share messages. But through WhatsApp and Facebook, we were able to engage more and we would also get feedback from them. And also what we saw was that through the PLH support, most of the recipient of care would open up or relate more to their peers. And that helped to create a deeper connection, which encouraged them to understand or seek more information on issues of routine viral load testing. And also in our context, most of the target audience, what we noted was that prior to the campaign, they were not aware of U is equal to U. And I think most of them were mistaking issues of low detectable levels, thinking that when they have results that say they have low detectable levels, that's translated to undetectable. But it took the campaign to clear out such misconceptions. And also in our context, what we noted through the campaign was that through working in collaboration with other partners and stakeholders within the HIV sector, but also the faith-based structures, we're able to reach more. And actually that helped to amplify the routine viral load campaign in our context. So yeah, more of what we were sharing. So like I said earlier on, we had priority platforms, but also through what we were sharing on Facebook and social media, other radio stations were interested to hear more of the campaign. So we got like spillover platforms where they would call us through various radio stations just to share issues of routine viral load campaign. So on my left, you can see we had an interaction through Timven Radio, which targets young people. So we had sessions that would run for 30 minutes on issues of routine viral load testing. And also through the support groups, we would have some drawings that would try to explain issues of U is equal to U. So in terms of the challenges and recommendations that we had, firstly, the challenges, I think with the COVID-19, we saw that in as much as we're creating demand through the campaign, there was limited availability of routine viral load services just because of the restrictions. And also at the same time, because in our country, we have a few labs that do routine viral load testing, or that, yeah, we have a few labs. So with that, with coming in of COVID, the same labs were being used to test COVID. So that affected availability of such services within our facilities. And we also had limitations on physical meetings, so we could not mobilize a lot of people. That's why I think our priority was to do more through the social media platforms. And also another challenge was that most of our PLHIV clients or our target audience were not aware of the guidelines, including some of the health workers, the guidelines on routine viral load testing. So it was actually the campaign that was helping to share more or shed more light on the guidelines. And also I think for us, the duration of the campaign was just less because the duration was a bit short. We did it for like 6 months from July to November. I think actually it was 5 months. So I think we needed to do more. And also the resources, I think for us, the campaign helped to reach a lot of people, but we're a bit limited in terms of the resources. And also I think in our context, we've had a delayed launch of the U is equal to U messaging. So every time we'd want to engage people on issues of U is equal to U, we had to be mindful. We couldn't actually go forefront because there's still those kind of delays. So yeah, in terms of the recommendations based on our challenges, for us, what we feel is there is still need for continued engagement of recipients of care, as well as healthcare workers on issues of routine viral load testing. We need to continue to build the capacity so that our target audience are fully empowered to demand routine viral load testing and also access results. And also what we want in our context is that MOH should fast track the launch of U is equal to U so that at least we should raise more awareness to our recipients of care. And I think the issue of making sure that in as much as there are other challenges like the COVID-19, but we should also prioritize in our context that the PLHIV community, who are our target group and audience, should still be able to access services regardless of other issues that are coming in that affect availability of such services. And also healthcare workers should also ensure that there's timely communication and thorough communication of routine viral load results, because they don't take time to explain. Actually, people are given their results, it just indicates that you are LDL, but that they don't interpret the results further to the client. So that creates gaps on the side of the recipients of care. So I think basically in our side, this is what we did as a campaign. Thank you so much for your attention.
Thank you very much, Caroline. Another very informative and clear presentation from Malawi. Just to confirm that colleagues from South Sudan are on, you're the next to share your presentation. Is Francis on? Francis or Victoria, are you on? Okay, so we seem to be having connectivity challenges with the team from South Sudan. We'll move it on now to the questions. We have some very interesting questions and comments in the chat. And then we'll get back and see if we can reconnect to South Sudan. So colleagues, very interesting presentations from the three presenters today. We've had the platforms that I use, the lessons learned, some of the coverage information available, challenges and ways forward. Now, I have very interesting questions and I will start with the first. So this will go to Pontsho and it is coming in from Jesse Wambugo. Jesse is asking, how do we mitigate against the potential negative effects that could arise from clients who show up for a viral load test after such a campaign but cannot get tested because of capacities that are not available to absorb the increased needs, stockouts, call it equipment downtime and other things? Pontsho.
Thank you so much, Jesse, for that question. I think this is the part where I was talking about, this is where we need to mobilize more and this is where community-led advocacy around these systems. So these two things can be linked. And this is also a way of creating agency within recipients of care where they are involved in campaigns that directly affect them. So I would suggest that in cases where the demand creation has happened and is successful, however, there's systemic issues such as the reagents, shortages, or viral load machines are broken, that what is done is that advocacy towards those issues is done, which involves the community, which involves people who actually, the recipients of care, in ways that are unique and can help in mobilizing the community towards a singular or the same task and objective. Thank you.
Thank you very much. Just to keep with you before I get to the other presenters. Innocent Twebaze is asking, what could be the reasons for comparably lower clients opting to ask healthcare workers about viral load testing?
I think this, and this is not something we looked out for, but from just my own experiences around this, I think it has to do with healthcare workers and the treatment healthcare workers give to recipients of care, and whether or not healthcare workers themselves know enough about routine viral load testing and what is that relationship between recipients of care and healthcare workers in particular settings. So for example, I did mention that key populations, particularly men who have sex with men, and people who inject drugs, sex workers, and trans people find it very hard to access healthcare in health facilities, even young people, and we saw that a lot of the campaigns reached young people. So this is not for a fact, but I would assume, or I would predict that it has to do with what the relationship on the ground with healthcare workers, with the local clinic is, and therefore this impacts. And also, we cannot shy away from the fact that HIV stigma still exists in many communities, and therefore perhaps it could be that asking about routine viral load testing means that I have to talk about being HIV positive, but on top of that, it could just be the lack of proper relationships on the ground.
Thank you very much. I am taking the next question, and this is coming from Pascal. And I will direct this question to Tonde Rai from Zimbabwe. And Pascal is asking, is there an opportunity to translate viral load test results into clearer outputs for patients? And she goes on to say, undetectable would be a simile, while detectable would be a worried of orange simile. Patients do not need to be bothered with RNA copies. They need to know what determines the next steps. So in Zimbabwe, are we giving patients pictorial results that depict what the results are, or we're just giving them text and copies? Tonderai, over to you.
Okay, thank you very much, Francis. Yeah, so I think that one in our setting or in Zimbabwe, in terms of similes, we have not yet come across that in our recent experience with recipients of care, because mainly they are being offered the text, and usually the results are explained in word format and their interpretation. And it also depends with the recipient of care. Some are very inquisitive, and then that's when they can engage with the healthcare worker and discuss more about the meaning of the results. But I think that is there's a good opportunity where we can develop IEC materials that shows those smellies to try and communicate viral load results to people, because I think what is also very critical is that as an individual, even myself, I don't like reading a lot, or if I see something that is text heavy, I might not give it too much attention. But if I see maybe pictures or something like smileys, then they might be able to draw my attention to try and understand what it means. And if I don't understand, I might go to the next person and ask, what does this mean? And engage in a conversation to understand each other. And so I think there's that opportunity, and it would be a good thing to adopt and move with it forward. Thank you. Back to you, Francis.
Caroline, can you take on the same question? What is the situation in Malawi?
Yeah, sure. So the situation in Malawi is not that different from what Tonderai has said. Actually, when communicating the results of viral load to clients, mostly the healthcare workers just write in their healthy passports, maybe LDL or something like that. But what we've noted in our context is that even though they write their results the way they've come, they don't even take their time to explain. So these recipients of care are just handed the results, and where we are having a lot of gaps in our context is that the recipients of care now, they fail to understand or interpret what that means when they get results that say LDL. And they don't even know maybe the thresholds, like, oh, okay, if my viral load maybe comes out to be less than 1,000 or less than 839 or something like that, what does that mean? So I think our context is not that different, and we haven't gone further to maybe use any other ways to communicate the results that would make it simpler for the recipient of care to understand, but also keeping in mind that there are others that have gone to school and would easily translate whatever has been written in their health passports, and there are others that haven't gone to school. They just received that result and off they go. They feel even less empowered to ask the health care workers. And I think, Pascal, you even asked why is it like that, that our recipient of care feel less empowered. Those are the issues that most of the times they rely on the service providers to initiate such conversations, even for them to be reminded that your viral load is due. We have had a lot of people that testified to us to say that until this campaign, I didn't know when my next schedule for viral load was because I don't know the frequency. Or oftentimes I just wait for the health care worker to tell me that now I'm due for the viral load. But where they don't say this, then I totally miss out. So those are some of the issues that we experience. And one other issue is the issue that people are scared of health care workers just because of the attitudes. You know, because most of them are overwhelmed. When someone tries to ask something, they don't get a positive feedback. They will be shouted to say, wait, I'm attending to other people. And, you know, people feel less respected or less valued. So most of them would just shun to say, until they tell me, I don't feel the need to ask. So those are some of the experiences that we have in our context.
Thank you very much. We now have South Sudan back on, and I will be directing some questions to the South Sudan team. Francis and team, you're very welcome back. Unfortunately, because of time limitation, we may now not go back to the presentation. So the question I'm directing to you, Francis, is, in terms of preparing for the campaigns and being able to make sure that the campaign results, and this is of course number of tests that go up, we expect that more people will be demanding for viral load tests. And so, because then the numbers go up, how have you been preparing your labs to be able to absorb the increased volumes of tests, given the campaigns that you are undertaking in South Sudan?
Okay, thank you so much. We actually apologize for going out due to network problem. In South Sudan, of course, we have been engaging mostly the facility, those ones, of course, who are directly involved with the clients, of course, to ensuring that any client who is due to viral load is being informed. And in terms of lab, of course, we have an organization that is called ICAP, who is directly involved in the laboratory process of the viral load. So I think in regards to labs, I will not have much information unless we try to also understand from the lab team who will be able to give us enough information. So I think Victoria also is online if she can add on the areas of the lab. But otherwise, we will always present and also dig deep in what is actually taking place in regards to the viral load program in South Sudan.
Thank you very much, Francis. Now, we are almost at the top of the hour and we are coming to the end of today's session. I will ask our presenters to, in 30 seconds each, please give us your closing remarks. And I will start with Francis again. Francis, some overarching closing remarks from South Sudan, given your experience with the campaign.
I think for South Sudan, there is really needs to expand the viral load program. It has really worked well for the few that we've engaged. And I think it will be a very good initiative if we really expand it to more areas and we're able to engage more clients, because most of the clients, of course, have very low knowledge on viral load in South Sudan, and there is need for them to be informed and continuously educated on the importance of knowing their viral load. I think that is what I can say. There is really much needed to be done in South Sudan in the areas of viral load. Thanks.
Thank you very much, Francis. Now, my next person making the final comments is Pontsho. Pontsho, as you make your final comments, can you also say something about institutionalizing some of these demand creation campaigns, other than having them as one-offs? Pontsho, over to you.
Thank you so much, Francis. Yes, I think it's quite important that these campaigns are continuous, as we saw that the results in the second phase were better than the results in the second phase, in the first phase. And this just shows that it can't be just a once-off experience, but the more we do, the more results we get. And so a sustained use of communications and advocacy tools for these issues will guarantee success in the long run. And so this looks at, I think from obviously it has financial implications, looking at donor or grants that are looking at communications and also communication system strengthening within community-led groups, because a lot of the time there is not a lot of money in grants for communications. Thank you.
Thank you very much, Pontsho. Sandra, your closing remarks in 10 seconds.
Okay, thank you very much, Francis, and everyone for listening to us. And we look forward to continuous collaboration in improving the viral load cascade. And from the community side, we appreciate your invitations and also your support, especially for us to engage in campaigns like this. And we look forward to strengthened collaboration. Thank you very much, Francis, and everyone. Over to you.
Thank you. And Caroline?
Thank you so much, Francis. I think for me is also to appreciate the time taken by everyone to be part of this session. And I think from our side, the campaign is something that we want to continue to take forward, because we've seen the power in raising awareness on issues of viral load, because in most of the interventions, I think the focus is diverted and much priority is not given to raising awareness on routine viral load. So I think in our side, there's more that we feel still needs to be done, and it's a call from various partners that let's engage, let's work together to raise awareness on viral load, but also to advocate for the required services, and also make sure that in amidst the COVID pandemic, issues of availability and accessibility of viral load services are prioritized. Thank you.
Thank you very much, and a big thank you to all the presenters and those who have been with us today. We apologize for overshooting by about 4 minutes, but it was inevitable. You have the code to access the certificates that demonstrates your presence today in this session. Should you require it, please get to that and get your certificates downloaded. We will then see you next time when we have the next session. And until then, good day to each and every one of us. Thank you again.
Thank you and bye.
Bye.